Thank you very much, Peter. My clicker is just there. That's fantastic. That's very kind for your kind words, and it's a real pleasure to be here in Melbourne. Last time I was in Australia, the only time I was in Australia was 20 years ago, and 20 years later I've managed to tag along a wife and 3 children, so things have definitely moved on in 20 years. So it's a real pleasure to be here. I've got about 15 minutes to talk to you. The title I was given was Successful Strategies for the Safe ED. I'm going to go fairly rapid fire through the slides, and then Simon's going to give an Australian perspective. This is where I work. It's Leeds General Infirmary. We're a major trauma centre, but in the city we see about 230,000 new patient attendances. The man in the foreground was the first ever ED consultant, Maurice Ellis, in 1952. Certainly the first in the UK, and some would say the first sort of dedicated A&E consultant. And so it's a real pleasure to work in Leeds. Leeds, the other great things about this place you can see is that the sun always shines in Yorkshire, for those of you who've ever visited Yorkshire, and we have very few ambulances. It's really quiet, and the last amazing thing about the place is that if you ever want to reduce demand, you should create a maze at the front of your hospital, and this produces exercise for the patients. So the story is that over the past decade, our attendances have risen, the complexity of work has risen, so the blue bars are the attendances, the red bars are the admissions, and by some quirk of disastrous fate, our system performance has decreased, our 4-hour system performance, and the last 2 winters have been the worst in the history of the NHS for the past 20 years. The last 2 winters are also coincide with my presidency. The two are not related. So it's all pretty bad. Our politicians have accepted the fact it's pretty bad. We've been trying to tell them that the problem is predominantly flow, because actually it's also got to do with the blue bars here are the total available beds. They've decreased by 15% in the past 7 years, and then the red bars are the number of occupied beds. The green line are the delayed transfers of care. So they've decreased the bed base, and the delayed transfers of care have increased. And that's the main reason. Our Secretary of State last year said it's because of the inappropriate attenders to ED. We beg to differ. There's also another really complex graph, which he, I think, grasped before he left to join the Foreign Office, was that actually if this is social care spending in the last 5 years has gone down by 10%. And remarkably, there seems to be an inverse relationship to the number of people trapped in hospitals who can't get out because there isn't enough community monies for social care. So I don't think it is inappropriate attendances, but there we go. So here's another one on predicting the future. So this is population growth. For mid-year estimates, the red bar from 2004 through to 2015 in the UK, 54,000 in England, and type 1 attendances. These are emergency department attendances which have steadily risen. There seems to be a relationship. Despite every diversion strategy for the last 15 years, attendances have risen between 1.5 to 1.8% per year. Compounded up, that's a 40% increase. And the great thing is you can predict the future. So the future is bright. It's orange or red. It's red. And the great thing is that our population will continue to rise. Complexity will continue to rise. if they do privatise the NHS and emergency care, buy some shares. It's all good. It's not going to happen, by the way. So that's all bad. My safety tip 1 is to have your system design so that you have best possible engagement and integration. I think the NHS has been pretty good at this for the last 15 years, but there are some significant cracks appearing. I think we have had better engagement from our colleagues in the rest of the hospital in recent years, in the last few years, and that has allowed us to dictate much more, to say that, for example, stable GP referrals out in the community shouldn't come to the emergency department. They are the remit of our colleagues on medical admissions and surgical admissions units. And that's decongested our departments to some extent. 15 years ago in Leeds, everything came through ED. It was pretty tough. We managed over a number of years to convince people that was not the right thing to do. But we still probably take about between 40 to 60% of stable GP referrals, despite all of that, because our physician colleagues don't seem able to consume their own smoke. They say things to us like, our ward is full, Taj, we can't really, and I say, well, my ED is full, but you can manage them. So it's quite difficult. So engaging the wider system is a good thing. I used to work for a regulator a few years ago for a while to go and see the dark side and see what it was like. And they asked me to contribute to a study. They'd done some amazing stats on why winter was so awful a couple of years ago. And they said, we think that the main problem is that we need to improve patient flow in the rest of the hospital. We said that was really, I said, that's incredible. I think we should publish that. And we did. And so that's all good. And then they didn't like my wording around social care. So they came up with, we need a better understanding, as opposed to, there isn't enough money. Anyway, and so there were some other pearls of wisdom in there, but you get the gist. I wanted that to be put in, but they wouldn't have that. Yeah, I think you call it access block here, but anyway. So we were mostly on the same page, and they've done some good stuff. So system engagement is crucial. Next, safety tip 2 is staffing strategies. You guys in Australia have done this really well over the past decade. I think we're catching up. I think that the issue around senior decision maker layers, depth and breadth of cover is vital. We're doing well actually in the UK in terms of our junior clinical workforce and the breadth of the different multidisciplinary groups that we have, advanced nurse practitioners, emergency nurse practitioners, etc. And I'll talk a bit about this key bit at the bottom, which is about attraction, recruitment and retainment. This happened at the end of my first year as presidency, after sort of really hassling our Department of Health around the last crisis 18 months ago, and to get the signatures of the 3 senior chief execs of the NHS to agree on a future workforce strategy that will define the next decade. And I think it's probably the best, and some of my friends would say the only decent thing I've done, which is not true. But at the heart of it is this business about growing the workforce. We're increasing our training numbers from 225 per year to 400 per year for the next 4 years, reducing attrition amongst trainees and trainers, and then making the working environment in terms of people as they grow older more attractive so that we retain our experienced workforce. That is a big deal for us. And the reason it's a big deal is my safety tip 3, caring for yourself and your team I think my college has done it. We've done a great lot of work in this area. We absolutely, all of us as emergency physicians, want to be in this zone. We want to be high performing. We know we work in the most intense environment. We know burnout is the highest amongst all the specialties, and that this is not fair. It's not fair on us. It's not fair on our staff. It's not fair on our patients. Not fair on our families. And so the college has done a range of work in this area. We're keen to help people describe that this is about portfolios, that, you know, emergency medicine is fantastic, you can do lots of things, an opportunity, and you need to give people those opportunities as part of the core work of being an emergency physician. Be in no doubt that there's lots of stuff out there. I was lucky enough to chair this group in 2012 at the college, and we produced a 100-page document. You can find it on our college website if you want to have a read, and it still holds as well today as it did back in 2012. We've been really forceful to our ED directors to be proactive in taking as much of this as possible. And I've spent the last 18 months now driving this through the Department of Health so that it comes from the top as well as from the bottom. So that I think I have no other message, but talking to de Villiers and others, you guys again are really signed up for this. Be proactive and be loved. Some of the clinical directors say, what about me? You know, it's a lonely business at the top, as it is for presidency. And my top tip for directors and resilience is this. So there's lots of human factors engineering in this exercise, and the best bit, which is at the bottom, I don't know if you can read, it says something about if unconscious, you can cease the stress reduction activity. Anyway, my time's moving on. I've got about 3 minutes. Safety tip 4 is about system metrics. So we absolutely believe in the 4-hour standard. What we don't believe in is people who game the 4-hour system standard and try to shove patients around in order to avoid breaches. 7 years ago, I was involved in a group with John Hayworth, a past president, and Matthew Cook, around developing 8 quality indicators that should have had equal weighting, and the 4-hour standard was one of those 8. So that these covered those 3 key domains of safety, timely clinical care, and system performance. The government didn't like that because actually it would have cost more money, and went back to the 4-hour standard, which is not good. Our view is that the ED metrics are about safety and timely clinical care. System performance is about linked to resource and capacity planning, staffing models, acute beds, community care, and that's the remit of policymakers and government to decide how much money they want to put on. If that's compromised system performance, it compromises safety. So the last one, we talked about demand, complexity, and outcomes. We talked about variation to some extent, some good systems, some really appallingly resourced systems. And the bit in the middle, the safety tip 5, is it's about collaboration, culture, and leadership. And I know from Simon and I have had this huge amount of coordination around this that he's going to talk about the most important topic next. And very lastly, in my last 30 seconds, just to showcase some of the good stuff that we do at the college. If you fancy looking at our safety section at the college, please do. There's some really good stuff there. I haven't talked about safety toolkits and safety huddles. I'm sure I'm absolutely preaching to the converted, but we've been doing some good stuff on that, so please do have a look at it. And I'm finishing, one of the things that we're really keen on is on leadership development. We're just about to instigate a program of leadership development for every single one of our trainees as they go through every year of their training. and also for, in the future, for our established consultants, and it would be great to collaborate with you. I think my time is out. We're a fantastic specialty, whether you work in the UK or whether you work in Australasia, and it's a pleasure to be here. Thank you.